It's a moment that honestly nobody wants to even think about. A loved one is in cardiac arrest, paramedics are doing everything they can, but what happens when it's not working? The hardest decision they have to make isn't what to do next, but when it's time to stop. So today, we're going to break down the strict, science-based protocols that guide what is, without a doubt, an impossible call.
It is such a heavy question, right? And it feels incredibly personal. But you got to understand, in the absolute heat of an emergency, the answer, well, it just can't be based on emotion. It has to come from a really carefully constructed set of rules that are designed to bring clarity right into the middle of total chaos.
Okay, let's dive right in. First, we're going to talk about why these rules are so critical in the first place. Then, we'll get into the baseline medical criteria that have to be met. After that, we'll look at how things like clues at the scene, the patient's own wishes, and even the type of injury play a huge role in the final decision.
I mean, just try to imagine making this call under that kind of immense pressure, with everything on the line. You absolutely cannot rely on guesswork, and that's exactly why these guidelines exist. They create a solid framework to make sure every single decision is consistent, it's ethical, and it's grounded in hard medical science. It takes that burden of uncertainty off the first responders.
So before we can even get into any of the specific situations, there are a few baseline medical facts that have to be established. Think of these as the absolute rock-solid starting points, the things that have to be true before we even start talking about these protocols.
Literally everything starts with these two words. First, you've got pulseless. Now, that's pretty straightforward, no detectable pulse. And then apneic, which is just the medical term for not breathing. If a patient doesn't meet both of these criteria, the termination protocols we're about to discuss, they just don't apply. Simple as that.
And from there, believe it or not, it gets even more precise. Paramedics hook the patient up to an EKG, and they're looking for one of two specific heart rhythms. The first is asystole. That's the classic flat line you see in movies. The other is called PEA, which means there's some electrical activity, but the heart isn't actually pumping. Basically, in both cases, no blood is moving. And to be absolutely sure, they have to confirm this rhythm in two different EKG views for at least 10 solid seconds. That way they know it's not just some momentary glitch. Okay, but, and this is a big but, there are some really critical exceptions. If a patient is severely hypothermic, all bets are off. They are always transported to the hospital. Why? Because being extremely cold can slow the body down so much that it actually mimics death, all while protecting the brain. There's this famous saying in emergency medicine, you're not dead until you're warm and dead. And for any patient under the age of 18, a doctor is always consulted online before any final decision is made.
So what about those calls where nobody actually saw what happened? Well, this is where paramedics basically turn into detectives. They have to piece together the story from clues at the scene. And the single most important clue they're looking for is what they call downtime, the estimated time that a patient has been in cardiac arrest.
And that estimated downtime? It changes absolutely everything. If the evidence at the scene strongly suggests a prolonged period, maybe the mail has been piling up for days, the protocol adapts. But on the other hand, if that downtime is at all uncertain, if there's even a chance it just happened, they are required to perform a full 20 minutes of high-quality resuscitation.
And yeah, that 20-minute number you see here, that is the benchmark. It's the standardized period of maximum effort. And it's based on a ton of data showing that if 20 minutes of really good, high-quality CPR hasn't brought back a sustainable rhythm, the chances of a meaningful survival are, unfortunately, almost zero. This chart just makes it crystal clear. Okay, look at that top row, prolonged downtime. The person was last seen 12 hours ago. In that scenario, even if they start resuscitation, the protocol says it can be terminated after just 10 minutes. Now look at the second row. The downtime is uncertain. They were just seen 20 minutes ago. In that case, the protocol demands that full 20-minute effort. It really is all about that initial context.
But, medical science is just one piece of the puzzle, right? There's also the patient. Paramedics have a profound legal and ethical duty to honor a person's wishes, especially if those wishes have been documented ahead of time in something called an advance directive.
And these documents, they come in a few different flavors. You've probably heard of a DNR, or a Do Not Resuscitate Order. Others, like a POLST form, are actually detailed medical orders for people with serious illnesses. But the goal for all of them is exactly the same: to give a person a voice in their own end-of-life care, even when they can no longer speak for themselves.
And to cut through all the noise and chaos of an emergency, some of these directives come with a very specific, very clear identifier, a bright orange bracelet for the patient's wrist or ankle. And its message is printed in bold, unmistakable type: do not resuscitate. It's designed to be absolutely impossible to miss.
So here's the bottom line. The most important takeaway here: if there is any doubt, they resuscitate. Period. If a form looks invalid, if the family is disputing it, or if there's any question at all, EMS crews are trained to begin CPR immediately and get on the radio with medical direction for clarification. The entire system is designed to err on the side of life.
Okay, last stop on our tour here. Let's talk about how these rules completely shift for what are often the most chaotic calls of all: traumatic cardiac arrests. When the injury comes from physical force, the protocols have to be different.
And this is where it gets really specific, because the type of trauma is everything. For what's called blunt trauma, think a major car crash, they can terminate if the patient meets those baseline criteria and their heart's electrical rhythm is extremely slow, less than 40 beats a minute. But for penetrating trauma, like a stab wound, the bar is set even higher. In addition to all of that, there must be absolutely no other signs of life whatsoever: no pupillary reflexes, no spontaneous movement, no response to pain at all.
So when we circle all the way back and ask how paramedics make this truly impossible call, the answer isn't simple, but it is clear. It's a methodical process. It balances medical reality, time, a patient's own autonomy, and the specific nature of their injury. These protocols don't exist to give up on people. They exist to provide an ethical, consistent, and science-based framework, making sure that one of the hardest decisions in all of medicine is also one of the most carefully considered.